Thank you, chairpersons. Thank you, Dr. Duseja, Dr. Singh, and the whole team of INAZL for kind invite, including a unconventional topic in this Congress. So going to celiac disease and liver disease. Look at celiac disease was thought to be uncommon, but now we know is a global disease. About every 70% in the world are seropositive for celiac disease, 1 in 70. If you look at about 0.7% of the global population have celiac disease. 0.7% means 1 in every 140 persons in the world have celiac disease. If we translate into these numbers, we have about 60 to 80 million people with celiac disease around the world. And in our own country, about 8 million people, 80 lakh people in our country have celiac disease. So celiac disease is now a global disease. We all believed celiac disease means enteropathy, means diarrhea, dyspepsia, but no. Celiac disease is a multi-system disease, and also why it's a multi-system disease, and they can have multiple manifestations. For today, we talk about hepatic manifestations of celiac, how liver get affected, and how many people with celiac have a liver disease, or vice versa. So this interest of liver disease in celiac came through a very important observation which happened in Finland. What they found, the 4 patients were listed for transplant, and while they were waiting for transplant, their serology showed they had diagnosis of celiac disease. They treated celiac disease and they came out of a transplant list. And therefore, they looked at their own cohort of 185 patients with post-transplant, and we found that 4% of them had celiac disease. Therefore, so this is the first observation, almost 20 years back. Since then, this topic became topic very important, and people started looking at a relationship between celiac disease and liver disease. So if you look at all celiacs, about 1/4 will have raised transaminases, 1/4. And if you treat them with a gluten-free diet, in majority of them, the enzyme become normal. Right? So if you look at, so I showed one spectrum is that increased transaminases, and if they remain undetected or untreated, they can have variety of progressive liver disease. They can have cirrhosis, they can autoimmune liver disease, fatty liver disease, also vascular liver disease. And let's come back to each one of them one by one. The first question, that of all CLD, of all chronic liver disorders, how many have a celiac disease? Again, 2 parts. One is the all-cause cirrhosis, and second part is cryptogenic cirrhosis. Coming first to all-cause cirrhosis. Again, this is a systematic review done by one of my students, Sakira, and what it showed that about 14% of all cirrhotics are seropositive for celiac disease. 14%, quite large number. But if you look at biopsy confirmed, 0.7. 1 in 140 cirrhotics have celiac disease. We also looked at our own data, and this work done by Ankit. He's a very bright resident. We looked at about 1900 cirrhotics, and what we found that about 175 have a raised serology, seropositive. 175 means about 9% are seropositive for all celiac. And if you go further, look at more than 10-fold were about 1.7%, 5 to 10-fold were 0.4%. Further on, these patients underwent further testing, including duodenal biopsy and also testing for EMA, that's the indomycin antibody. And what we observed that 35 of them had celiac disease. Of 1900, 35 had celiac disease, meaning thereby the prevalence is 1.7%. So 1.7% of all cirrhotics in our country have associated celiac disease. And interestingly, that many of these patients have one more etiology. They were alcoholic plus celiac. They have a B virus plus celiac. So if you don't investigate for celiac disease in them, we are going to miss them. Because each one had some etiology, like fatty liver disease, B virus, autoimmune liver disease itself. So therefore, 2 things I want to say here, that small number, about 2 per 100 cirrhotics will have celiac disease, and they may have associated other etiology. Coming to second part, that those who have cryptogenic cirrhosis, again coming to Sakira's systematic review, about 5% of all cryptogenic cirrhosis have celiac disease. 5% of all cryptogenic liver disease or cryptogenic cirrhosis have celiac disease, right? And coming to 5%, right? Coming to our own data from our center, this is work done by Aditya. Aditya looked at all cryptogenic coming to our center. He looked at about 300 cryptogenic liver disease, right? Of that, 232 were included in this study. And what Aditya showed that 11 patients had a definite celiac disease and 5 had a potential celiac disease. Meaning thereby of 100 cryptogenic, 5 have celiac disease and 2 have potential celiac disease. Same as what we observe in a systematic review of global literature. So coming to other liver disorders, autoimmune liver disease, about 3.5% of all autoimmune liver disease have celiac disease, right? And coming to one other interesting thing is NCPF. Again, this is data by Aditya again. We looked at about 100 patients with NCPF, 77 included, and what we observed that about 8 of them, of these 77, had associated celiac disease. Further, fatty liver disease. People know that celiac disease is a disease of malabsorption. They should be lean thin. They shouldn't have fat. That's not true. Of all, this is again systematic review, of all patients with celiac disease, 15 have fatty liver to start with, right? And if you treat them a gluten-free diet over 1 year, 14 more are added. So 29 per 100 will have fatty liver disease. Same is metabolic liver disease. To start with, 4 will have metabolic liver disease, and as you treat the gluten-free diet, about further 11 are added to it. So 15 per 100 become metabolic liver disease. And therefore, this also is an important consideration while treating patients with celiac disease. Putting them together, that what we find that of all cryptogenic, 5 per 100, of all cause cirrhosis, 1 per 100, 3.5% of autoimmune, and 10 of all NCPF have associated celiac disease. Coming to, now this is a celiac. Now look at global perspective. In the whole world, how many of people have cirrhosis, and of those cirrhotic, how many have celiac disease? Again, this is data which is global data. 112 million people have cirrhosis. They decompensate into 12% per year, so 11 million decompensated. Of these people, how many have celiac disease? We said 1% of all cause cirrhosis celiac disease. It means the 1 million cirrhotic in the world have celiac disease. And of those, decompensated 0.1 million, right? And if you look at cryptogenic, of all cryptogenic, 10% of are cryptogenic of all cirrhotics. Therefore, of 11 million, about 0.5 million of all cryptogenic around the world have celiac disease. So therefore, celiac disease is an important cause or important factor while you treat patients with liver disorders. So what? There are numbers. So what does it mean? As I said, that those patients who have a liver disease, they have a high mortality. They also have a lower survival. But how do we stop it? 2 things. Stop etiology. What we do for C virus, what we do for B virus. But treating etiology is the factor. So if celiac is a cause of progressive liver disease, treating celiac disease makes sense. And this is what we know from data in other liver disorders, that be it alcoholic or be it hepatitis C virus, if you treat them, their liver outcome becomes better. Are we convinced about it? If you treat etiology, the liver outcome becomes better. Am I right? Therefore, treating celiac disease will be better. Look at our own data. Again, this data from Aditya's study, which I showed, 5 per 100 cryptogenic have celiac disease. So what we did in this group of patients, we have 44 celiac cirrhosis, and we took 44 match control and followed them up. Over 1 year, we found there was a better in terms of CTP score, better in terms of MELD score, and also in terms of liver elasticity. Meaning that by treating celiac, you're making differences in their liver outcome. So coming to what do we do? So all cirrhotic patients, it's time now to look for celiac disease in them. And if you find, many will have false positive TTG, but again, do EMA and do biopsy to confirm diagnosis. So, if you look at how it happens, what is the pathophysiology, why liver gets affected, and to explain to that, let me go back how celiac disease happens, what is the pathophysiology. So we know that we eat gluten, celiac disease 2 factors, gluten and genetic predisposition. So you take gluten, these peptides are there, so these peptides are not broken down completely into amino acids because we don't have an enzyme called polyiindopeptidase. Therefore, the whole protein is not digested, but we remain peptides. These peptides pass through enterocytes, the paracellular route. As they pass through, they get deamidated by TTG, which is just subepithelial. As go by, there are peptides which are there in lamina propria. They're picked up by antigen-presenting cell, and these peptides binds with HLA. This peptide is deamidated and then attached to HLA, and then HLA help a T cell. T cell gets IL-2, B cells, and then clonal expansion, and this T cell infiltrate enterocytes and leads to damage to intestine. So the center of celiac disease now is well established. We know why it happens. This is gliadin reactive T cells. So this is the expense of T cells which leads to celiac disease or damage to multiple organs. And these T cells are really loaded. They have a lot of characteristics. And now we can pick up these T cells by using tetramer. So if somebody is exposed to gluten, if they have a gliadin T cells, we can pick up by using tetramer technology, which is now we also doing at our own center. So now coming to liver disease. So how liver get affected in celiac disease? As I said, the center of celiac disease is a gliadin reactive T cell. So these T cells infiltrate the small intestine, but they also infiltrate other organs because they circulate in the blood. Suppose they come to the blood, they come to blood, go to liver, so they get liver damage. So they do chronic hepatitis. So ALT rises. As we see, 25% of patients with celiac disease do have ALT. Once ALT increases, if we don't treat them chronic, they become chronic liver disease and cirrhotic. But if you detect at this point of time when they raise ALT, you detect them, treat celiac disease, everything is reversed. But if you're not doing that, they will have progressive liver damage and lead to cirrhosis of liver. So what are evidences? Evidences of liver disease and celiac disease are mainly till now are because of observation by doctors, by different clinics. They find those who have liver disease, some of them have celiac disease. And also by reversal of liver disease in them. There are no direct evidences. What could be direct evidence? The direct evidence could be that demonstrate this T cell in the liver or demonstrate the TTG in the liver biopsies. So therefore, we showed that those patients who have a celiac liver disease, they have an take half a minute more. So we have shown that this anti-TTG is deposited in the liver. And as we treat them, this deposition of TTG get abolished, confirming that if you treat celiac disease, liver damage gets better. The more important, we want to demonstrate that if we can define these T cells in the liver and take liver biopsy and demonstrate there they are gliadin reactive T cells. Now we have technology using tetramer. And this work is done by Sambuddha, who is our PhD student. With that, putting everything in a summary, we know celiac disease is a global disease and 1% of the world have celiac disease. 5 of 100 patients with crypto have celiac disease. 1 of 100 of all cause cirrhosis have celiac disease. 3 per 100 of autoimmune have celiac disease. And 10 of 100 NCPF have celiac disease. So what? Treating them is an opportunity. So screen them for celiac disease. And if you treat them with gluten-free diet, even they have one more etiology, there is a better outcome. With that, thank you for your attention.
Yeah.
Thank you, sir. Excellent presentation. Is a negative IgA TTG sufficient to rule out celiac in a patient with cirrhosis? or do we need to do more tests like biopsy and serum IgA levels and
No,
others?
if TTG is negative, then probably the chance of patient having celiac disease is very, very low. Because most patients with celiac disease will have TTG positive, they are IgA. Some small number, maybe 2-3% people may have a IgA deficiency, where the test could be negative. But if you suspect high, then you should do IgG based tests like IgG DGP antibody.
Govind,
Good.
you mentioned the causality in cryptogenic cirrhosis, but how is the association established between autoimmune and vascular? You said even those had a higher incidence where you found celiac disease. So how is that explained?
Crypto is easy to understand that if, what no scenario, raise ALT/AST, no GI symptoms, so therefore they remain asymptomatic and develop chronic liver disease. In that time they come with decompensation, we do all etiology and find that none is positive, we call cryptogenic. And if you screen cryptogenic, you find celiac in them. So therefore, the point was, again, second point is vascular liver disease. Their data, we have patients, I think Dr. Sood, Ajit Sood and many other colleagues have a patient with HBOTO, do have celiac disease. We just saw that the NCPF 10% have celiac disease. I'm not sure this is because of direct causality or direct relationship, but they are at this point of the association, but I'm not sure there's a causality in that.
Or is it just because in your part of the country celiac disease incidence is much higher? It will be worthwhile looking at the other parts of the country and association with celiac disease.
I want to just discuss one point, that celiac disease, wherever in the world people looked at celiac disease, they found. It's just because we don't look at it. 20 years back, we didn't look at it in Delhi. We now look at, we find. In 20 years' time, no disease comes up. So therefore, openness is important.
So you're suggesting we should be screening all our cirrhotics for celiac disease?
I would do that. I would do that because I look for autoimmune, I look for copper in every patient, I look for iron in every patient. I hardly find it. Celiac is an opportunity. If you diagnose, you might improve liver outcome. It's as simple. It's a simple test, 500 rupees, 1000 rupees, it's worth doing.
Very nice talk, Govind, I think, and very nice work and impressive data which you're doing. I just, one of the query which Rohit just raised is, there's good amount of data to say that cirrhosis as such can have TTG levels which are high. Which actually means that should we just rely on that marker, or you need to do the EMA or a duodenal biopsy in everybody, because as I said, TTG just positivity may not be equivalent to celiac disease in cirrhosis. I think this is what the data says, number one. The second is, cryptogenic liver disease is absolutely acceptable. Whether it's an association, cause and effect, obviously, I think will be difficult. It's easier to say in cryptogenic, but what I'm question is on the all-cause cirrhosis, which you said, and the data which you showed. Now, there you already have a etiology, which is alcohol, which is mast cell, Hep B, Hep C, and you get a TTG positive, which is, say, even 2 positive. But you also said that there's a prevalence of celiac disease in the community. Now, how much is that contributing to liver disease in people who already have one etiology? I think that I am I'm not really sure on that. Unless, as you're saying, your work which you're showing, histologically, if you show that yes, celiac is causing something in the liver. So other than the T cell things which you're seeing in the liver, there's some entity called celiac hepatitis also used to be there. So are there any morphological features which can connect them better? Because otherwise, I think in somebody who already has an etiology, it may be a little difficult.
I take your second question first. So we know that about 14% of patients in our own series, 8% of all-cause cirrhosis have a positive serology. But positive serology may not mean, I don't think, we know dermatitis herpetiformis and celiac disease, well established. 1/3 of patients with DH do not have enteropathy. So celiac disease is like an umbrella disease. Something drives, you have a predominant small intestine disease, you have predominant skin disease, you have predominant liver disease. We don't know, this is my own thinking, that this would happen. Therefore, not many patients with cirrhotic may have a TTG positive, they are not to be treated. They are first confirmed, do EMA, do biopsy in them, intestinal biopsy, and if you have evidence, you treat them. Coming to second etiology, again, We always knew that alcoholic, the diabetic, they have both liver disease. They have a fatty liver disease because of alcohol, fatty because of metabolic liver disease, metabolic causes. If you want to liver outcome, there's one treatable disease. I don't want to sell my idea today, but I want to raise this question to your mind that would you think of thinking celiac disease in them? If you find, why won't you treat them? Because if you're treating celiac disease, even 1 in 100, in a liver disease, you do nothing. What else you do? You just palliation. Treating etiology is the hallmark of liver disease treatment. You want to change outcome, treating etiology is the factor.
Yeah, I think he has been standing. Yeah.
So in the background of celiac hepatitis, your liver function will be hyper transaminases and all those things will be there. At the point of time, they have been advising only treat first strategy. We'll be going for gluten-free diet for a duration of around 6 months to 1 year of period before considering the patient for liver biopsy. What is your opinion in that, sir?
No, you don't do liver biopsy at all. If somebody has celiac disease and if you have a raised ALT, you wait for it for 1 year. That certainly you do for B virus and C virus, which are more common. You look at alcoholism, look at fatty liver disease. But if they are not there, the 4 most common cause, you won't do liver biopsy. Just wait, give gluten-free diet for 1 year. If no response in ALT, that time this ALT is not because of celiac disease.
But then almost most of the entity will be having a coexisting autoimmune parameters. So without liver biopsy, how can we conclude that, sir?
So at the end of 1 year, you want to establish this ALT is because of celiac or not. In celiac disease, 1/3 or say 1/4, 25% of patients with celiac disease have raised ALT, and therefore you will treat them with gluten-free diet. You're treating celiac disease. If they are celiac-related enzyme rise, they get better. What Ajay says, celiac hepatitis, that's what ALT, AST rise is celiac hepatitis.
Thank you, sir.
Yes,
My question is regarding non-cirrhotic portal fibrosis. So in that also the prevalence is high. You've shown
10%.
10%. That means
9 of 77.
So is it because the patients have been screened in North India, or it's like, and that means that all non-cirrhotic portal hypertension patients, including NCPF and maybe EHPV also, we should screen for celiac?
EHPV we haven't seen systematically, but we do find some patients with EHPV. This is how my interest rose, that we find small children coming with EVL and we find celiac in them. We don't have data on EHO at all.
So this is the North Indian data where the prevalence of celiac is high.
I just want to request one thing.
Is it an association only, or?
It could be association. I just want to make one last point that let's not think of North India and South India.
So
let's not think of
Yeah.
North and South India. Every disease occurs everywhere. You just want to look at it.
Yeah.